many inhalers were actually developed to make things easier for patients over time. And that's an important thing to note because inhaler therapy, estimates vary. And of course, it's a very subjective type of number. But, you could think of it that inhaler therapy typically requires patients to do about 80 to 90% of the work simply to get the drug to where it needs to be, which is, of course, deep in the lungs. So it's much more nuanced than, if we think about swallowing a pill. It's kind of like a binary choice. You swallow it or you don't.
PodcastRx.
PodcastRx.
PodcastRx. PodcastRx.
Welcome to PodcastRx from Diamond Pharmacy, a show featuring the pharmacists and personnel behind the nation's largest correctional pharmacy provider. While we talk primarily about clinical and regulatory topics affecting the institutional healthcare clients we serve, we'll also occasionally get into the stories behind the people moving our company forward. This isn't just a pharmacy podcast, and you don't have to be a clinician or a pharmacist to enjoy it. On this episode, Chris Bender from the Optics Clinical Pharmacy team stops by to preview his upcoming NCCHC Spring Conference presentation on proper inhaler use. With some 38 possible inhaler therapies available for asthma and COPD, providers can be easily overwhelmed and out of breath with the choices. I talk with Chris about demystifying inhaler therapies for better patient and cost outcomes, along with the factors behind higher asthma and COPD rates in the correctional patient population, the mechanics of inhalers, inmate security considerations, and more. If you're going to NCCHC at the end of April, be sure to check out Chris's entire presentation. I'm Adam Campbell, and this is PodcastRx. Chris Bender. Good to have you back in person for the first time in a while. How are you?
I'm doing well, man. How are you?
Oh, doing great.
It's nice to be back in person.
Certainly is. I mean, we obviously, you and I record many of these shows, but most of them are remote these days. So it's good to have you back. The energy's different. Can't deny that when it's in person.
Absolutely.
And a little different energy today because today's Eclipse Day.
Yes. Yeah. Hope everyone got their glasses. Hope everyone's ready to roll. I know I will be.
Yeah. Just a few hours here. We'll be at 97% totality where we're at here in PA.
Exactly. Yeah. We're pretty fortunate. We don't have to drive over to Erie to see it.
That's true. I actually got some friends that are up there today for that. And thankfully one of them is from there. He's just going to his mother's house.
Oh, that's nice.
Doesn't have to brave all the craziness that no doubt is going on up there.
Yes.
But let's hope that the clouds open up in our part of the world a little more so we can really get the full thing. But yeah, Chris, you're back in because you're heading to NCCHC later this month, talking about exciting happenings. You're heading to the Spring Conference on Correctional Healthcare in St. Louis, and you're giving another one of your presentations. I'm curious, how many presentations have you given at NCCHC since coming to Diamond in 2017?
I want to say this is my fifth. I think fifth or sixth, at this point. Yeah. So at this point, I'm kind of well-versed in going down there, which is like always an awesome time.
Yeah.
So I'm excited to go down again.
Excellent. What are you most excited other than presenting? And we'll get into that. But what about St. Louis in particular are you looking forward to?
What's funny is I've actually never been to St. Louis before. Okay. So I'm interested to see what they have to offer. I'll be in town for a couple of days. So I'm always, as we all are, I'm a bit of a foodie. So I'm excited to see, what kind of good food I can get down there. And then also too, from like the conference perspective, it's really nice because once you've been to a few of these things, you kind of see the usual cast of characters. Right. And like we've developed a rapport, me and my colleagues with like a couple of these different people. And I know speaking from my own perspective, like I've seen people there every year and it's like the one time that we have, to catch up. A couple different providers, they'll come up to me and we'll talk for a little while. So it's always really nice just to have that opportunity to reconnect with people that you haven't seen in a year. Yeah. So that's probably like the best thing about it.
Yeah, no doubt. Well, the presentation you're going to be giving is titled Better Breathing Through Proper Inhaler Use. And this actually ties back to a podcast, an NCCHC preview podcast that you did 2 years ago, Updated Asthma Treatment Guidelines. We did a podcast about that, and that's episode 20. Episode 20, if you want to go back and listen. That's a good partner podcast to this, what we're going to talk about today. What factors brought you back to the subject of breathing treatments, asthma, COPD for 2024?
Yeah, so, the main reason that I wanted to do this specifically is because I, of course, along with my colleagues in our optics department, we get asked about inhalers a lot, like almost a daily basis, both for asthma and COPD. And then obviously, I think that's really because, number one, asthma and COPD treatment recommendations, they're not as similar as they perhaps used to be, or as we would like to imagine that they are. And number two, there are just so many inhalers on the market that it's often difficult, for providers to keep them all straight and for them to feel confident that they're choosing the right one for their patient's particular situation. Another reason that I wanted to revisit this subject is because if you'll recall, back in 2020, my presentation was solely focused on the then recently updated asthma guidelines. So, it was a deep dive into the nuts and bolts, the nitty gritty of that guideline, but it was fairly limited in its overall scope. So this time I wanted to provide a brief review of both asthma and COPD treatment. But I feel like the heart of the presentation is actually a discussion on the various inhaler types, what makes them different, how to choose an appropriate device for a patient, and ultimately, how we're going to maximize their inhaler therapy, whether it be with proper inhaler technique and, in some cases, even the use of spacers and even holding chambers.
I just want to say, Chris, what I really love about the presentation topics you often pick, and which then translate into podcast episodes here, is the practicality of it. And this is a very, very practical discussion.
Yeah. And that's why I was, it's fun as a clinical pharmacist to kind of like get into the weeds and talk about the nuts and bolts of a disease state and talk about the guidelines. But at the end of the day, that's only going to get you so far because providers still need to relay the hows to the patients. And, especially, this being not just providers, but also nursing staff and ancillary staff at these conferences, I like to provide a little bit more practical information to people because that's ultimately like, how are we going to implement this information?
Right. Well, let's set the stage a little bit. Talk about the overall prevalence of asthma COPD in the incarcerated population versus the community. In that episode 20, you cited a number from a 2015 U.S. Department of Justice report that the prevalence of asthma among the correctional population was 15 to 20% versus 10% in the community at large. Are these numbers, to your knowledge, still essentially the same in 2024? And just to review, why is there such a pronounced difference between the general community and the correctional population?
Yeah, it's interesting because in preparation for this, I wasn't actually able to find any good updated information on that figure. So, just judging from my own perspective, I would have to imagine that 2015 estimate is still fairly accurate. Now, it is unfortunate, though, because, it can be difficult to find good health statistic data, particularly as it relates to those in corrections. And this is possibly due to the constant turnover in that patient population. Now, I will say there are estimates out there that suggest that asthma prevalence is 30 to 60% higher in individuals with a history of incarceration compared to the general population, as you mentioned in the lead up to the question. That's pretty much jives with the numbers that we had talked about back in 2020. Now, there are many potential factors that could play a role, but asthma and COPD, as we know, are highly influenced by lower socioeconomic status, substandard living environments, as well as tobacco exposure. And unfortunately, many of our incarcerated individuals have at least some, if not all, exposure to these factors, which could explain the prevalence increase in these individuals.
When you're talking about asthma and COPD as disease states, for these purposes, statistics or just even just talking about them in the literature, they counted the same. I mean, you see so interchangeably used like in your presentation and elsewhere. Yeah.
And so like I said, there's not great data, on this in corrections. Now generally speaking, you do see asthma and COPD independently reported, but with the correctional data that we have, they're usually just reported as asthma. So I would have to imagine that they are being counted one and the same in this case. And simply because while I was able to find hard estimates for asthma, I wasn't able to find any for COPD. And, giving people the benefit of the doubt, it could be because it's often difficult for providers, let alone correctional staff, to tell them apart.
Well, regardless, you have this higher prevalence of asthma COPD, and then you get to the available therapies, the available inhaler therapies to treat it. And there's a lot out there. So, Chris, how extensive are the available inhaler devices and therapies? Can you put this in numbers?
I have a few numbers for you.
All right.
And this is part of the presentation because I like to kind of highlight this fact because it's sort of it's a good way to look at the landscape, and it's also kind of mind blowing in a way. So there are essentially 5 different medication classes that are available in inhaled form. There are 3 basic inhaler types. And then there are 13 proprietary inhaler devices that differ from manufacturers. All of that ultimately adds up to 38 unique inhaler brands that are currently on the market. All of that leads to one giant headache for both patients and providers, of course.
It's almost like echoing Neil Armstrong there.
Exactly.
But 38, and that's such a, it's just such a particular number, 30.
It is. And that's why every year there's a, and I'll mention this in the presentation as well, but I don't have any skin in the game with the Asthma and Allergy network, but they actually put together a really nice, like a poster every year. It's visually stunning. It has all of the inhalers on there, and you can download it for free from their website. And I can actually, for those interested, I'll provide the link
we'll put that in the show notes
because I personally use it every year. I just go in and download it every year. And this time I just counted them, just to see how many were on there. And it was kind of like stood out to me, but it helps me because it keeps them straight. I can see them in their classes and stuff. But yeah, it's pretty wild out there with how many there are.
Right. Well, Chris, for those of us of a certain age, let's ask the Avril Lavigne question. Why'd they have to go and make things, in this case inhalers, so complicated?
Well, nicely done.
I mean, it's cringeworthy, I know, but
but I appreciate
it gets to the heart of it.
listen, I am of a certain age, and I really appreciate that earworm. But don't forget, that she answered her own question in the opening lines of that song with, that's the way it is, because life's like this. So that's the answer to that question. No, I'm just kidding.
Memories unlocked.
So in all seriousness, though, I don't really think that the intent was ever to truly make things complicated, but rather, many inhalers were actually developed to make things easier for patients over time. And that's an important thing to note because inhaler therapy, estimates vary. And it's a very subjective type of number. But, you could think of it that inhaler therapy typically requires patients to do about 80 to 90% of the work simply to get the drug to where it needs to be, which is, of course, deep in the lungs. So it's much more nuanced than, if we think about swallowing a pill. It's kind of like a binary choice. You swallow it or you don't.
Right.
So, kind of a rhetorical question for you is what do you typically think of when you think of an inhaler, right? Like you probably think of that metal canister, the one that you shake, you press it down, and then that puff comes out, right? So we call that a metered dose inhaler. Now, those, of course, were like the standard for years. But unfortunately, with those, it can often be difficult because it really requires a high degree of coordination for the patient to be able to press and inhale simultaneously in a way that the medication goes into the lungs and it doesn't land in the back of the throat, which, can be difficult to do for some. Well, drug companies identified this as being a common problem, and they went on to develop dry powder inhalers, which actually work by the patient loading the dose, and then they inhale that dose whenever they're ready. So in this case, their inhalation is ultimately what sets things in motion. So that's why dry powders are, even to this day, one of the most common types of inhaler. They're very, pretty easy to use from that perspective. But the problem is you need to have the ability to inhale really forcefully in order to get that powder out of the inhaler, because you think powder is heavier than like an aerosolized air. And in some patients, like those perhaps with advanced COPD, they don't have as much of that inspiratory ability. So, in a continuous evolution process, one drug company actually created a soft mist inhaler, which is still sort of like a metered dose inhaler. But rather than a fast puff, the medication comes out in a slow mist fashion, which actually makes it one of the easiest inhalers to breathe in.
Well, given what you said there about, you don't think the intent was ever to make things complicated. Admittedly, Chris, I can't help myself but make another cringy song reference. But isn't it ironic, don't you think, that in an attempt to make therapy easier, it got more complex?
You got the whole album covered, man. This is fantastic.
Yeah. I'm sorry to the listeners.
No, that's great, though. It is kind of an ironic twist, though.
Right. But so with all this in mind, then, as a pharmacist, where do you start to simplify treatment recommendations for inhalers for the providers and ultimately for the patients?
Yeah. So obviously, we're dealing with 38 inhalers. So I often as I can, I try to limit the number of options that I'm throwing out to the providers when I'm, speaking with them. And I usually try to give them the most cost-effective options first, since cost is obviously a concern in all settings, no matter where you are, but particularly in corrections, sticking to budgets and whatnot. So, this way, rather than talking through 38 possible inhalers, I can work through a progression of, say, 3 to 5 inhalers. And, that's often easier. 3 to 5 names is often easier for providers to kind of work with in their minds, or, even, pharmacists and anybody to work with in their minds. I then try to simplify the treatment algorithms. So to be clear, it's often recommended to take a targeted approach with asthma and COPD based on their symptoms. And this, of course, may require multiple inhaled medications right off of the bat. But since we don't always have the most complete patient information in corrections, some providers may choose to simply start with one agent and then kind of step up and add from there. So in this way, I can walk them through a simplified algorithm that is basically like, okay, let's start with this inhaler that contains drug A. If the patient isn't doing well, or if that doesn't seem to be enough, then we can switch them to this inhaler that contains both drugs A and B. Obviously, I then recommend that they follow up with the patient closely to see if they're able to use the inhaler properly, because obviously if not, then they can call me back and we can start to discuss alternative inhaler types that I may not have mentioned before, like switching from a dry powder inhaler to a metered dose inhaler, for example.
How successful would you say it is, like that first recommendation, like what you just detailed? We start off with that. Does that work most of the time, first time through? Do you have a lot of follow-ups, or just in general?
So it's kind of interesting from my perspective, right? Because I don't always get to see the closing of the loop in a lot of cases, which to me can mean one of two things. It means that if I don't hear back from the provider or from the nursing staff who called me, maybe it did work perfectly, and that's why they're not calling me back. But then again, it's also easy for them to perhaps forget to call back or something like that. So I don't, in all honesty and full transparency, I don't often get to see what happens as a result of that. But there have been a few instances where, sort of in a different way, nursing staff will call me after they've already identified that the patients have been having problems, and without me prompting them. And I can often explain to them, this is probably why the patient is having problems, because they're on a dry powder inhaler. They probably don't have the ability to breathe in that heavily or that forcefully. So let's switch them to this. And oftentimes that usually goes over very well. So at least from my perspective, it seems as though the recommendations are taken very well. Whether it lands is somewhere we're kind of in the dark a little bit from our perspective.
Sure. Well, Chris, I want you to, this is something I know you like to do, to explain something like the listener is 5. So explain to me like I'm 5, what is the essence of proper inhaler technique, and what are some common mistakes that patients make?
Yeah. So I want everyone to remember, I had said before, there are 3 basic inhaler types. So those are metered dose, dry powder, and soft mist inhalers. But the basic tenets of using them are all roughly the same. So the patient prepares the dose in some way, which, depending on the inhaler, may involve twisting the inhaler, pulling a lever, or even removing the cap sometimes loads the dose as well. The patient then breathes out fully, should be, breathe out fully away from the container or from the inhaler. Then they put the inhaler in their mouth and they inhale. This part is actually the biggest difference between types. So for dry powder inhalers, remember it's a powder. So patients will need to take a quick, forceful breath. Whereas with the metered dose and the soft mist inhalers, they should actually take a long, slow breath. And then after that, the patient should hold their breath for 10 seconds if possible before exhaling. Probably one of the biggest areas where, the most common confusion or misstep is people often think that they have to take a really big forceful breath with the metered dose inhaler, because I actually kind of blame the, Hollywood or whatever you want to say, because we see it in television where they kind of propagate that poor technique where you see them real quick, pull it out of their pants and they shake it real quick. And then they just do like a really quick hit off of the thing, which is counterintuitive. You kind of need to do it a lot more slowly and in time with the inhalation. Otherwise, they get a lot of that dose in the back of their throat. So that's probably one of the biggest things. And another thing that we have to kind of think about is shaking. So the meter dose inhalers, those being the canisters, of course, those do get shaken. But the dry powdered ones, because they have powder inside, it's actually not recommended to shake. So I've actually seen in some instances where a patient could even load the dose, have it prepared, and then if they shake it, they can pour the dose right out of the mouthpiece of the inhaler.
Oh, no.
So those are probably the biggest mistakes that I see happening.
Yeah. Well, in addition to those mistakes with the corrections environment, you have security considerations. So what are some common security issues that you have to address with inhalers? And
this is actually, one of the most surprising and probably interesting parts of inhaler therapy that I learned whenever I started working at Diamond. And that's the fact that many inhalers actually contain metal screws, springs, or even needles. So, whenever I was working in the community, these aren't really reasons for concern. You don't think of these devices being taken apart or anything like that. People use them, they throw them away. But in the correctional settings, these actually could be considered contraband, at least the pieces within. Since the metal, of course, could be used to forge weapons or other devices. For example, the Spiriva HandyHaler actually has 2 needles that are used to pierce a powder-filled capsule in order to then inhale the powder from the capsule. Well, those needles have actually been used to create makeshift tattoo guns. So this is an additional factor that facilities often take into account when they're deciding on, which inhalers do they prefer, or whether specific inhalers can be given to patients to keep in their cells and on their person. So it's interesting stuff, really.
It certainly is. I'm never not impressed by the creativity.
Yeah.
And whether drug diversion or fashioning an inhaler for a tattoo needle. That's a new one. It's
very resourceful, very creative. Yeah. And what's interesting is, I often have, when a new inhaler comes out, I've started simply calling the manufacturer just to see directly. And it's the person on the other line is usually like, why are you asking this question? Yeah. But I have to lead with, okay, so working predominantly in corrections. This is why I'm asking you this question. So it's always very interesting. But there are cases where they don't have that information. So that's where the arts and crafts come in. And we've even in the past have actually broken an inhaler just to see what was in it in order for us to have an idea.
Wow.
Yeah.
Well, are there times then where some patients just have to use those in a supervised setting? Like you talked about sending them back to their cells. Is there just times where that's just not an option? Yeah,
which is really difficult because some inhalers, there's a very small subset of inhalers that are called rescue inhalers, right? So that being like albuterol and levoalbuterol, stuff like that. Those, of course, are the ones that you need that on your person because if you're having an exacerbation, you need that. You can't go to the nurse's station during a pre-specified time and wait, for that. So fortunately, we are able to find specific manufacturers that are without the metal and stuff like that. Those are the good instances because then they can keep them on their person. They don't have to worry about the facility doesn't have to worry about those specific inhalers. Now, unfortunately, a lot of the maintenance inhalers, the ones that aren't necessarily for acute on-demand use, they contain a lot of the metal and stuff like that. So those are typically kept under direct observation, depending on the facility and what their threshold is. But fortunately, in those cases, those are more like scheduled medications. So we're not worried about a patient not having access to a critical medication when they need it.
Gotcha. Well, you're going to talk a lot more about all of this at NCCHC. And we don't want to give too much away for the presentation since this episode is going to drop before then. But did want to ask, Chris, for those who are going to go to NCCHC, what are your biggest takeaway goals for your presentation? What do you want to send listeners away with?
Yeah. So first, I would like the attendees to understand that asthma and COPD are treated differently. It's kind of the first half or so of the presentation. Get a general feel of how they should be treated appropriately. And then second, I want them to leave with the understanding that the choice of inhaler device should be tailored to the patient and what they're actually capable of using, of course. In many cases, the patient will be able to use the most cost-effective option that the facility tends to prefer. But in some cases, they may need to switch to a sometimes more expensive inhaler in order to actually use it. And that's the point that I'm going to try to convey, is that even if a patient does need a more expensive inhaler, that may still be the more cost-effective option for that patient in the long run, because we're going to be avoiding all of those subsequent exacerbations and potential send-outs to the hospital.
And that's just one general observation as we've had this conversation, is mentioning cost effectiveness. When you do have 38 inhaler options, I would assume that, that an upside to that is you do have more cost effective options just at the ready.
Yes. And it does allow us to play within the groups of medications to find that most cost effective option, which really helps, like I said, from the correctional budgetary standpoint, which is fantastic.
Right. So after the NCCHC conference, will there be any way, if anyone's interested in seeing your presentation or listening to the webinar, any way that they can request that, get in touch?
Yeah, absolutely. So I believe the same as last time. We'll have a recorded version of this presentation, and it'll be available on Diamond social media after the conference ends. So it'll be available in an on-demand fashion.
Yeah, we have a brand new Diamond website that we could add that to.
Awesome.
Have under our blog feature.
Yeah,
and just
it's easy for me to say, you're the man who's got to upload it. So
yeah, we can definitely do that. Well, Chris, I want to thank you so much for taking your time again today while you're in person. It's good to see you. Good to chat with you. And again, let's reiterate where and when can people find you at the upcoming NCCHC Spring Conference on Correctional Healthcare?
Yes. So I will be at the Diamond Pharmacy Services booth in the exhibit hall on Monday, April 29th. So obviously feel free to stop by and say hello. And my presentation will be Tuesday, April 30th at 8:15 a.m., bright and early. It is session number 133, and it's entitled Better Breathing Through Proper Inhaler Use. This is my full disclosure. I really wanted to name the presentation Don't Fear Vlad the Inhaler, but I had to sort of restrain myself on that one. So I'd be happy to see anyone and everyone who's able to stop out.
Well, there's nothing stopping me from calling this podcast Don't Fear Vlad the Inhaler. I won't, but I appreciate you, man.
Hey, always appreciate you too. It's always a great time catching up and chatting on the pod.
All right, Chris, until next time, which will be probably very soon. Take care.
Take care.
PodcastRx features conversations with healthcare professionals. The statements and opinions discussed herein are for informational purposes only. This podcast should not be considered professional medical advice and should not be used as a substitute for the advice of an appropriately qualified and licensed healthcare professional. Therefore, listeners must not rely on the statements made herein. But we do hope you enjoyed them.
PodcastRx is a production of Diamond Pharmacy Services, the nation's largest correctional pharmacy provider. Keep up with our show on all the major podcast platforms, including Apple Podcasts and Spotify. New episodes usually drop the first full week of each month. Where possible, please rate and review the show to help us reach more listeners. If you have any questions or feedback for PodcastRx, we'd love to hear it. Shoot us an email at podcastrx@diamondpharmacy.com. We thank you again for listening.